Hi, my name is Lakshmi Yatham. I'm a co-chair of ACUMEN, a WFSPP e-learning program on cognition for clinicians. The focus of today's module is going to be cognitive functioning in bipolar II disorder. Some of the things that we're going to try and cover in this module include things like, do patients with bipolar II disorder have cognitive impairments? And if they do, what domains of cognitive functioning are affected in bipolar patients? How can clinicians assess cognitive functioning in bipolar II patients? And what might be some of the strategies clinicians might employ to address cognitive impairment in bipolar II patients? Kate Burdick is an associate professor at Harvard Medical School, and she's an international expert on cognitive function in bipolar II disorder, and she's here to talk to us this morning. So nice to have you, Kate, in this program.
Thank you. Thanks so much, Lakshmi, for inviting me. This is a really important topic, and I'm really excited to talk to you about it today.
Wonderful. So let's start with a simple question, and that is, I think most clinicians are aware that patients with bipolar I disorder have cognitive problems, and clinicians often think bipolar II is a milder form of bipolar illness. So the question is, do bipolar II patients also have cognitive impairment?
Yes, so there's a simple answer, which would be yes. There's a slightly more sophisticated answer, I think, which is some bipolar II patients absolutely will have cognitive impairment, while other bipolar II patients may not have particularly pronounced impairment. This is also true to some degree within bipolar I disorder as well, the heterogeneity that exists in the disorder.
Okay, so if they have cognitive impairment, the bipolar II patients, what's the sort of magnitude of impairment? How bad is it?
Well, so in general, if you look at the sort of group of patients with a bipolar II diagnosis, you tend to see deficits, depending on the phase of the illness, that range from about 1/2 standard deviation to about perhaps almost up to 1 full standard deviation below normal relative to non-psychiatric healthy controls.
Okay. So you mentioned that patients with bipolar II disorder as a group have cognitive problems.
Right.
And I'm assuming that means that some people don't.
Right.
So can you tell us about what proportion have and what proportion don't have those cognitive problems?
Sure. So generally speaking, what we know about the number of participants with bipolar II that have cognitive problems is probably somewhere on average of about half of the patients. And of course, it depends on the severity that you're looking at. Some bipolar II patients will be quite severely impaired, while others show relatively mild impairments. And then again, perhaps about half of the sample will not show any significantly clear impairments relative to healthy people.
Okay. So if bipolar II patients have cognitive problems, and we know that they experience these hypomanic symptoms and depressive symptoms, so the question is, the impairments that we're talking about, the cognitive impairments, are they present mostly when they have symptoms, or are they present even when they have remitted from those symptoms?
Yeah, it's a really important question, and one we've learned a lot more about in the more recent years. It used to be thought that it was only problematic that cognition, attention, and memory problems would occur during depressive episodes, and to a lesser extent, hypomanic episodes. But what we now know is that many of the deficits that we see in bipolar II patients are quite persistent, which means that we can do a reasonably good job of treating the affective symptoms, and many of these cognitive deficits continue to persist even after the remission. This is particularly important because these are the deficits that are most problematic for patients with regard to their everyday function.
Okay, so we can't just assume that someone has cognitive problems because they're depressed. It sounds like from what you're saying, even if we get rid of those depressive symptoms, they continue to have these cognitive problems.
That's right.
Okay. You talked about the magnitude of impairment in some of these people, ranging from half a standard deviation to up to a standard deviation. Mm-hmm. I guess the question is, how does that matter? Does it matter for patients? Does it matter from clinicians' perspective?
Sure, absolutely. So it kind of gets back to the point of those persistent deficits once you're able to treat the affective symptoms, and those that just aren't targeted well by medication or other kinds of interventions. And the reason that it matters is because when patients struggle with organizing their schedules, when they struggle with paying attention and concentrating, this tends to reflect in either not having a job, not being able to keep a job, or perhaps even if they have a job, not doing as well in their daily performances as they could be. And so these deficits are really very critical, not just to occupational status, but also social status and various other aspects of daily living.
That's very interesting because, in good old days, when we treated people with a bipolar disorder, whether it's bipolar 1 or 2, and we use medicines or psychological strategies to improve their mood symptoms, and patients come back to clinics saying, I'm still not right. I'm still not ready to go back to work. And, the perception or the belief those days was that, the patients are lazy, they don't want to get back to work. But it sounds like from what you're saying, it's perhaps that cognitive impairment that was making them feel that way. So there's really an explanation as to why they were feeling that way.
Yes, absolutely. And I think there's now pretty clear objective evidence that that's the case. When you do neuropsychological testing, when patients are remitted, these deficits are there. So it isn't just the perception of the patient. These are real cognitive problems that are keeping them from optimally functioning in the world.
It just underscores the importance of listening to patients, isn't it? So don't be dismissive, kind of thing.
Right, absolutely.
Right. So if cognitive functioning is affected in bipolar patients, and of course we know there are multiple domains of cognitive functioning, right? So the question is, are there specific domains that are impaired in bipolar 2 patients?
Yeah, so another good question. I think generally speaking, we see a relatively global appearance of the deficits that are seen, which means that multiple domains of cognitive functioning are affected in individuals with bipolar 2 disorder. There's some evidence that suggests attention, concentration, and verbal memory. So difficulties remembering things that they've heard, retaining information, and sort of keeping it in their memory. These domains tend to be particularly pronounced in bipolar 2. The other, which is important to know, is executive functioning. Executive functioning covers a very big concept in terms of cognition and the various skills that it requires, but multiple aspects of planning, organizing, the ability to think flexibly tends to be pretty impaired in patients with bipolar 2 disorder.
Okay, so all domains, but perhaps some more than the others,
Right,
it sounds like.
right.
Okay. So we talked about cognitive impairment in bipolar 1 and bipolar 2 patients. And you talked about the magnitude of impairment in bipolar 2. Mm-hmm. Is that same in bipolar 1, or is there really a difference in terms of the magnitude of impairment?
Yeah, so there is a difference in terms of the severity of impairment. Technically, we think that in large part bipolar 1 patients who experience the full manic and sometimes more frequent psychotic experiences within the disorder have more severely impaired cognitive problems than patients with bipolar 2. It's generally thought that it is because of the full manic and psychotic symptoms that bipolar 1 patients experience, that bipolar 2 patients very rarely experience. However, there's still a lot to learn about that. And more recent evidence, within the last year or so really, has suggested when you compare directly bipolar 1 patients with bipolar 2 patients, you do see differences, but the differences are really quite subtle.
Okay, so that's the severity of the impairment. What about the quality of deficits? Is there a difference at all, or?
In terms of the types of domains that are affected? Yeah, so my sense of that is that the profiles that we see and the qualitative types of impairments are pretty similar among bipolar 1 and bipolar 2 patients. It's mostly a severity difference. There are a few studies that suggest that executive functioning deficits, for example, are slightly more impaired in bipolar 2 patients than bipolar 1 patients. So you may see a little bit of a qualitative difference, but generally speaking, you tend to see a similar profile.
If bipolar 2 patients have these cognitive problems, what happens to those cognitive deficits over the course of the illness? Because as we know, the illness starts fairly early on, mm-hmm. and with treatment and with the further episodes, do those impairments change at all, or and
Yeah.
if so, in what way?
Right. So this is a really important question in the field in general, and we're just starting to learn a little bit more about that, the course of the cognitive problems, the trajectory in different patients. In most bipolar 2 patients, you will see, generally speaking, what looks like somewhat of a degenerating course. So a cognitive decline that occurs over a long period of time in the illness itself. It tends to track with the chronicity of the illness, so how frequently patients spend time in the hospital, how often they have severe episodes that are occurring. The decline was once thought to be associated more directly with repeated manic episodes. And so in bipolar 2 patients who don't experience full manic episodes, we thought perhaps that decline may not be as pronounced. But it does seem that over the course of the disorder, many patients will show a drop in cognitive functioning that seems to be accumulating over time.
Okay, so that's interesting because that's somewhat different from what one sees in people with schizophrenia, right? Because my understanding is people with schizophrenia have deficits pretty much at the disease onset, about 1.5 or 2 standard deviations, and that seems to persist, whereas in people with bipolar, from what you're saying, yes, there are deficits, and in fact, they actually could get worse with the progression of the disease with more mood episodes.
That's right. And so what we do see, and one of the differences just in the general clinical presentation between bipolar disorder and schizophrenia, is the episodic nature in bipolar disorder. And while in schizophrenia you see some differences in sort of residual remitting phases, most patients with schizophrenia will have some level of psychotic symptoms quite stable throughout the course of their disease. And so there's not as much fluctuation in even the clinical symptoms associated with the disease. And it seems that that might be why bipolar disorder differentiates from schizophrenia in this way, where we have the repeated episodes in the bipolar patients that are contributing over time to cognitive problems.
Okay, well, that brings us to another important question, and that is, what are some of the causes of cognitive problems? And of course, you mentioned these repeated mood episodes are the duration of the illness. What might be some of the other things that might be contributory to these cognitive problems that we see in bipolar patients?
As you know, bipolar patients can have quite a number of different comorbidities and other problems that are associated with having the disease, but not directly part of the disease itself. Things like substance abuse, poor dietary habits, a limited amount of exercise, the kinds of things that we know are good for cognition more broadly are contributing over time to patients' well-being in general, and certainly to their cognitive functioning as well.
So you talked about mood episodes contributing to cognitive problems in bipolar 2 patients. What might be some of the other reasons that bipolar 2 patients may have cognitive problems?
Yeah, there's a number of other things that contribute to cognitive problems in patients with bipolar disorder. Generally speaking, they have often a relatively complex disease where there are multiple different kinds of comorbidities. So quite commonly, patients with bipolar will suffer from substance abuse as well as anxiety disorders that are on top of the existing bipolar illness. And so those contribute directly to how people function cognitively, including patients with bipolar disorder. So these are some of the complexities of the illness that contribute.
Okay. So what about medications? Because sometimes patients, when they come into the clinic, will say, I've started taking medication X, and I'm having, problems focusing or remembering things. Mm-hmm. So we understand some of the illness-related issues might affect cognition, but do we know whether medications can actually have a negative effect on cognitive function in bipolar 2 patients?
Yeah, so there's surprisingly limited systematic evidence on this question in terms of looking again at objective deficits that are seen. Many patients have these subjective complaints of cognitive problems that are associated with changes in the way they're thinking that is often related to a medication, and in some ways the way the medication is doing its job to sort of tamp down some of the mood-related components of the disorder. There's not a lot of objective evidence that suggests that psychotropic drugs that are used to treat the disease are particularly deleterious in terms of cognition. However, I would make the general statement that in many cases, we certainly don't see any clear evidence of these medications helping cognition as yet. And in some patients, I'm sure that there are cognitive side effects that are real and that are causing some problems for the patients.
Okay. So we'll come back to talk about some of the strategies clinicians might want to employ to address those things.
Yeah.
But you talked about some of the illness-related issues causing cognitive problems. You mentioned the effects of medications. The evidence is really not clear at this point in time. What about any biological correlates of cognitive impairment? In other words, do we know anything about, changes in any chemicals that might actually explain some of the cognitive stuff that we see in bipolar II patients?
Sure. Again, a relatively new area of research in the field, but one that seems to be making a lot of progress pretty quickly. One of the most recent and well-supported hypotheses is the idea of neuroinflammation occurring as part of the episodes that we see. So there's some evidence that when you look in peripheral blood, you can see these pro-inflammatory markers, so cytokines and things that happen when you have a cold or when you have a fever, that your body's fighting off stress in some way. During manic episodes and during depressive episodes that are severe, there's some evidence that these peripheral and probably mapping to neuro inflammation markers go up. The idea is that they then recover after each one of these episodes, but over the course of the illness, they don't recover fully. And so you see a kind of cumulative effect of these inflammatory markers that overall, when are in a chronic state, are not good for the brain. And so the idea is that that's contributing in large part to the changes you see over the course of the disease in cognitive functioning.
Okay, that's very interesting because, we often think of inflammation as a non-specific kind of thing as well, right?
Yes, I think it is. I think it is a non-specific thing. I think it is one thing that is contributing to what we're seeing in patients, but it's also associated with a lot of things that are associated with the illness. So things like increased BMI or heavy, dietary changes, other kinds of things like substance abuse or trouble sleeping. All of these things can affect inflammation and certainly are part of this illness as well.
Okay, so I wonder if anyone has looked at the efficacy or effects of anti-inflammatory agents in improving cognition. Do we know?
We don't know yet, but there are some studies that have been done, some small trials that indicate that at least a subgroup of patients with bipolar disorder, specifically those who have objective evidence of elevated inflammation at the time of the baseline of treatment, will show some benefits. This has not been looked at so much specifically for cognition as yet. But I think it's promising, and we have seen some effects in antidepressant trials where we're looking at those patients who have inflammation at baseline do better if you treat them with an anti-inflammatory drug over time.
Interesting. So an area that's worth pursuing, it sounds like.
Yeah, I think so.
Coming back to clinicians, from clinicians' perspective, I suppose, just thinking that, if I have a patient with a bipolar II in my clinic, should I be thinking about then routinely assessing cognitive functioning?
Absolutely. So I think this is one thing that we still haven't quite, as a field, gotten the word out to all clinicians, with the idea that when you have a patient who comes into your office who's acutely manic, you have a very specific thing you need to take care of. Once you've sort of treated the primary affective symptoms of this illness, it's really critical that patients are assessed for cognition in order to promote full recovery, because these are the persistent deficits that don't seem to track as well with treatment for the affective symptoms. So I think it's incredibly important that the field moves to understand that this is a real domain of problem for a patient. And so assessing it is the first step.
Okay. Well, as you know, clinicians are incredibly busy and they don't have expertise. And for that matter, they probably don't have access to a neuropsychologist, I suppose, to refer patients for comprehensive neurocognitive functioning assessment. So I'm just wondering, are there some simple tests that clinicians can administer to these patients to get a sense of whether or not there is any impairment?
Yes, absolutely. So again, I wish there were more tests like this in terms of being able to give these resources to clinicians, because it can be a complicated area. There are a few that are now publicly available and freely available for clinicians that are shown on the ISBD, or the International Society of Bipolar Disorder website, where a clinician can access some of these measures. So the two that happen to be on that website are called the SCIP. The SCIP is a small battery that can be administered by an untrained clinician, untrained in the neuropsychological assessment. The advantage, and the thing that's particularly critical, is that it has normative data. So I can do a test with you, and then I can go into the normative data and say, based on your age and your gender, we can understand that you have a deficit that's of some magnitude, or you don't. And that assessment can be done pretty quickly. It only takes about 15 minutes. That is a more objective measure that's available. There's also one called the COBRA, which is a more subjective questionnaire, so asking the patient in more detail than you might do in a regular visit about their cognitive functioning, about how they're doing in their daily lives. And that also provides a good picture and an important component to understanding how the patient is perceiving their problems.
Okay. So if I'm going to assess cognitive functioning in bipolar 2 patients, should I wait for them to remit from their mood symptoms before I do the assessment, or does it really matter?
Ideally, you should wait for remission or something that looks close to remission for the patient. There are some patients, of course, that will not achieve full remission in frequent cases. And so in that case, you would still want to assess cognition. But ideally, the best potential time to do it is during an affective remission, because the symptoms themselves can present and differently in terms of their correlates of cognitive problems that patients have. So assessing them during that euthymic period is important to understand, again, those persistent deficits that are the things that contribute to functional problems in the world.
Okay, so I've assessed the cognitive functioning in my bipolar 2 patient, and of course, if the person doesn't have cognitive impairment based on those tests, then that's fine. But if the person has the impairment, then what do I do as a clinician? What are some of the strategies that I should be using to address those cognitive problems?
Yeah, so the first thing is, as you kind of alluded to in the first question, repeated assessment. So one of the things you want to do is, if you do identify a cognitive problem in a patient, to have that as a baseline. And certainly over some period of time, you're going to want to check whether or not that's getting worse, whether it's improved. So the first answer is continue to assess. If, of course, the deficit is very profound and kind of out of line with what you would expect to see in the patient, that might provoke the referral to a full neuropsychological exam. But in terms of trying to intervene or trying to improve the problems that patients are experiencing, and once you've identified them, generally, a lot of the kinds of things that we think about as good brain health more broadly are good recommendations to make for patients, including things like getting very good night's sleep, trying to have regular exercise, and these types of things that are known to be beneficial to our cognitive functioning as human beings.
Some people would say, particularly for preventing dementia, do puzzles, things like Sudoku, that kind of stuff. So you talked about some lifestyle strategies for minimizing these cognitive problems in bipolar 2 patients. What about things like Sudoku and other types of brain exercises, so to speak?
Yeah. So some of these things are very easily accessible to all of us, crossword puzzles and various kinds of brain exercises, you sort of think of them as. The evidence suggests that they are actually effective in helping people maintain cognitive reserve, sort of hold on to what cognition they have and not see the decline that occurs with dementia and perhaps with bipolar disorder as well. I think this has been shown now, at least in relatively large studies in healthy individuals. As we age, we lose some of our cognitive skills, and these kinds of somewhat simple and fun game sorts of approaches actually seem to be protective against cognitive decline. There are other more specialized kinds of brain training exercises that fall under the rubric of cognitive remediation, which is usually a more structured kind of approach. But it's based on the same idea that if you exercise your brain, it will treat you well as well over time.
Okay, so that was going to be my next question, and that is, what do we know about cognitive remediation and its efficacy in improving cognitive problems in bipolar II patients?
Again, not as much as we would like to know about cognitive remediation as yet, but there are a few studies now that have spent a good amount of time trying to assess different types of cognitive remediation. Most of these are computer-based kinds of training exercises, and they tend to be relatively intensive in terms of having a patient come in and do these types of exercises on a computer over 12 weeks, coming in 3 or 4 times a week. And so sometimes the burden of that kind of approach has been problematic. It's not easy for any of us to commit to kind of that regular schedule of doing these things. And so for patients with bipolar disorder, it can be even more challenging with their other problems in their lives. But the limited data that we do have suggests that it's promising. There are not yet any clear, this is the package that I think is going to be the answer for our cognitive remediation approaches. But several trials have shown some change that has been associated with some functional improvement as well. Things like being able to work more productively in their jobs and those types of functional components.
Okay, so it sounds like from what you're saying, if you have someone with a bipolar II that has significant impairments in cognitive functioning, in addition to some of those lifestyle strategies that we talked about, you're saying it's probably worth referring them to a cognitive remediation program because potentially it might be beneficial.
Yes, I think that's fair to say. Despite having somewhat limited evidence yet, I think it certainly can be helpful and will be helpful for some patients.
Okay. What about medications? Because I know you've done some medication trials. Mm-hmm. Is there any evidence to suggest that any medications that are available might be beneficial in improving cognitive function in bipolar II patients?
Yeah, so there's, again, limited evidence on this topic, and I think there's an enormous amount of enthusiasm in the field to start to look at this question. And to date, there are some agents that have some promising data associated with them, many of which we think about as potential agents to treat things like attention deficit disorder and some of these more stimulant-based types of medications. The drug modafinil has some evidence from some depression studies, seems to show some promise in terms of treating cognition. Likewise, there are a few other dopamine agonists that seem to be effective to some degree. I do think that there will be a point at which we need to combine those two strategies where we're able to find a medication that at least primes the system in such a way that improves cognition enough to get patients in front of the computer to do the cognitive training that can be quite burdensome over time. So these approaches have so far been relatively separate from one another. They both have some promising evidence, and I think over some time we'll put those two things together.
Okay, thank you. So we've covered a lot of things related to cognitive aspects in bipolar II patients. And I'm just wondering if you were to distill some of the things that we talked about today, what would you say might be 3 key take-home messages for our clinicians?
Yeah, so I would start with the probably what I think might be the most important is the idea that it needs to be assessed. So cognition is a problem for many patients, and it has been neglected to some degree over time, and in many cases rightfully so. The primary aspects of this illness can be very pronounced. The manias are absolutely an urgent scenario in terms of treatment. But we need to start asking patients about cognition. We need to start formally assessing cognition before we can even think about what to do about it and how to fix it. So I think that would be number 1. I think it's an incredibly important thing for clinicians to do. I think number 2, I think that educating the patients about these types of deficits could be incredibly important as well. We do now know enough about these deficits, about some of the causes of these deficits, and certainly promoting good life behaviors such as exercise and reducing substance abuse and some of the things that we know are contributing that patients can modify is an important thing. So identifying these modifiable risk factors and getting patients to be aware of these things can help their overall outcome. And then let's see, so number 3, I think, more specifically to bipolar II disorder, I think this is something, again, that, as you said, I think right in the beginning of this conversation, it was for a long time thought that bipolar patients in general didn't have cognitive problems that were particularly concerning outside of the episodes. I think when we started learning about that and understanding that, it was then felt only bipolar I patients have these problems. We don't need to worry too much about it in bipolar II patients. I think now the bulk of the evidence is clear that that is not the case. In fact, many bipolar II patients have objective problems that are really contributing directly to functioning and just absolutely need to be considered as serious and treatable.
Wonderful. Thank you so much, Kate, for talking to us today.
Thank you.